One of the big concerns of patients is what sort of follow-up should I have? What scans do I need? What blood tests do I need? If a patient has undergone surgery, then I'll often assess the patient as to whether or not any lymph nodes have been involved. If, for example, the patient has had a very small appendix neuroendocrine tumor, then actually they often don't need any follow-up at all. Let's take the example of a pancreatic neuroendocrine tumor where a patient has had surgery, and then the question is, well, what sort of follow-up should I have? How do I assess the patient? And that applies actually for the intestinal tumors as well. First of all, I'll check whether or not it's a grade 1 or a grade 2 or a grade 3 tumor. The more aggressive the tumor is, the more frequent the follow-up will be. For a localized tumor, then you could say for a pancreatic neuroendocrine tumor, if a local lymph node's involved, I will restage the patient usually 3 to 6 months after surgery, not before, with a gallium octreottate PET scan. The reason why not before is that you can get false positive uptake if you rescan too soon. So often patients will have, provided they had a positive scan before surgery, will have a gallium octreottate PET scan 3 to 6 months afterwards. If that's all clear, then you could argue for a low-grade tumor, grade 1, or a grade 2 tumor but with a lower Ki-67 proliferation index, that such patients might be reviewed 6 monthly for the first year or two, but then could go to annual review. If after 5 years, then everything was clear, some people would say, well, you could stop surveillance. I suppose I'm a little bit cautious. I think it may not be unreasonable to do that if one knows it was low grade and all the tumor had been removed at the original operation. The caveat is that these tumors inherently are very slow growing. So if one's going to stop active surveillance, one would say you would definitely need to come back to your doctor should you get new signs or new symptoms so that you could be scanned at an early stage. I have a tendency to follow up patients on an annual basis long term, and after 10 years one might then say we'll discuss what the pros and cons would be to follow up the patient, because one has to take into account radiation exposure, and that's important. Although there's no radiation exposure with MRI, although there's some debate now about contrast and MRI, and so you don't necessarily want to be having too much in the way of repeated contrast with MRI scans as well. And it's not anything that's definitely proven, but it's a caution that in the radiology world one would say you don't repeat contrast MRIs unless absolutely appropriate. The timing of any gallium octreottate PET scan, again, because of the radiation exposure, you might scan at 1 year and then maybe at 3 years. But you have to discuss with your consultant why you're choosing a certain follow-up protocol. And he should be able to discuss with you the grade of your tumor, the stage of the disease, what was involved at the time, for example, of the surgery, and therefore his rationale for following you up. And there's a lot of variation, there's no set protocols, but what his rationale for following you up is, taking all of that into account. If, however, you've got advanced disease, as many patients have, and the disease is there within the liver and the bones, you want to make sure that you can pick up any change in the growth at an early stage. And I'm sure that part of the benefit in terms of the increased survival that we've had over the last numbers of years is because we're detecting the change in growth at an earlier stage. And so for standard tumors, for the grade 1 and grade 2 well-differentiated neuroendocrine neoplasms, following up with a CT or an MRI on a 6-monthly basis is entirely appropriate. If it hasn't been any change and it's very small volume disease, then it may not be unreasonable just to have a once-a-year scan as well, and many centers might follow that. If, however, for patients with larger volume disease, it's causing some symptoms, then certainly following up on a 6-monthly basis seems appropriate. You might do a gallium PET scan on a once-yearly basis, and the gallium PET scan picks up disease not often identified on the CT or MRI, particularly related to the bones. And so therefore once a year or once every 2 years, one would be tempted to do a gallium octretate PET scan. Doing serial blood tests is helpful because the chromogranin A blood marker is quite a good marker. It's the best marker we have just at the moment. There's new tests coming through that you'll read about, the one being the NET test, but it's not validated yet and not available yet in common practice. But the chromogranin A is the standard marker that we use. And for all its faults, if you're seeing a rise in the chromogranin A blood test, then that would suggest that there's a possibility of tumour growth. And in that instance, you may have more frequent scans, whether that be CT or MRI, or even possibly a gallium octretate PET scan. And of course, the other time that one would be followed up is if you're getting more symptoms. And that would be a time to approach your doctor and say, I'm getting more in the way of abdominal pain, or I'm getting much more in the way of hormonal symptoms. Could that be reflecting the tumour growth, and should I be needing a scan? And that's where discussion with your doctor and your specialist nurse is important.